Welcome back to the PMSF scientific sessions of the We Are Family Conference. We have a great session today focused on sleep with Dr. Beth Mallow, and we also have a guest moderator, Dr. Alicia Halliday. I will introduce her in 1 second. Without further ado, I will share our sponsor video, and then I will introduce Dr. Halliday, who will introduce Dr. Mallow.
Our mission at Jaguar is to accelerate breakthroughs in gene therapy for patients with severe genetic diseases.
With gene therapy, we can give the opportunity at a better life. That's what makes Jaguar special.
It is my pleasure to introduce Dr. Alicia Halliday. Many of you know her, but Dr. Halliday is the Chief Scientific Officer of the Autism Science Foundation. Prior to this role, she served for 9 years as Senior Director of Research for Clinical and Environmental Sciences at Autism Speaks. She runs a collaborative group called Agenda, focused on rare genetic neurodevelopmental disorders, and she's president of PMSF's Board of Directors and is involved in many of our projects. She also has twin daughters, one of whom has ASD, and she's passionate about providing families with scientific information and deciphering scientific findings for the community. Welcome, Dr. Halliday. Thank you for being here with us.
Thank you so much for inviting me and for allowing me to moderate this session. It's really my complete honor to do so. I want to introduce Dr. Beth Mallow. Dr. Mallow is the Burry Chair in Cognitive Child Development and Professor of Neurology and Pediatrics at Vanderbilt University Medical Center. Her clinical and research interests focus on improving the health and quality of life for individuals with intellectual and developmental disabilities across the lifespan. She was inspired by raising 2 sons with autism who are now in college. She's published more than 130 peer-reviewed articles, along with multiple books, book chapters, and review articles. She serves as the core director for translational research at Vanderbilt's Kennedy Center and the principal investigator for Vanderbilt's Autism Care Network, which is one of 12 regional centers across North America, which develops standards of medical care for children with autism. She's carried out foundation, industry, and federally funded trials of melatonin and behavioral sleep education in autism, including in community settings and conducted via online portals. I was kind of giggling to myself because you certainly can't find a more qualified expert in the field of sleep medicine for people with autism spectrum disorders in the country or even the world. So without further ado, I wanted to make sure she was introduced properly, and then I want to hand it over to her. Thank you, Dr. Mallow, for agreeing to participate in the We Are Family series this summer and fall.
Thank you so much, Alicia. I have been such a big fan of yours forever, especially in the last year. I got very interested in doing science communication, and I'm taking formal classes in it and really trying to become a better communicator of science to the public and trying to decipher it. And I just love your podcasts for the Autism Science Foundation, and it's just so good. I just want to make sure everybody is aware of it, and you do such a lovely job with that. So I'm thrilled to be here and to have you introduce me today. So I'm going to go ahead and share my slides. As I'm doing that, I wanted to mention I have 2 sons on the autism spectrum. They're both college age now. They're doing really, really well, and I'm really glad that I was able to help them with their sleep along the way and all of that. So I'm going to go ahead in the next 40 minutes or so, 35, 40 minutes, and talk about sleep disturbance in neurodevelopmental disorders. And I just want to mention my disclosures. I do consult to Neurum Pharmaceuticals. They are developing a micro tablet of extended release melatonin. So I'll mention that a little bit later, but I did want to disclose that. And then I will also disclose that we'll talk about some off-label uses of medicines for sleep and neurodevelopmental disorders, because there are no approved medications for kids with or without neurodevelopmental disorders right now by the FDA. Everything is pretty much off-label, meaning where there's no clear indications. We just kind of work with what we have. So a lot more work has to be done in this field of understanding treatments, but we'll get to that. What I'm going to focus on today, three things. One is I want to identify the types of sleep problems that are common in individuals with neurodevelopmental disorders. And in addition, I'll touch on Phelan-McDermid and what I've been learning about it, because you're teaching me along the way, and I'm trying to understand it myself. And so your input will be great in the Q&A and some of the other interactive things we planned. And I want to also understand the causes, or help you identify the causes and contributors to these sleep problems. And then we'll talk about established treatments, emerging treatments. And I also want to do something fun and mention some research we've done with online toolkits and other approaches to treatments in the era of COVID-19. So we've had some really interesting times, right? And some really good ways to try to get information out to parents. So I'll try to share that. So I wanted to start out and put this in context. There are many developmental disabilities with prominent sleep problems. Certainly autism spectrum disorder. These are in alphabetical order, but autism spectrum disorder is probably at the top of the list just because autism is so common now, affecting in some series as many as 1 in 44 children. So it is really important to keep that in mind. But then there are many others like Angelman syndrome, Down syndrome, and certainly Phelan-McDermid syndrome has been associated with sleep problems. And this is one of the articles that I found in getting ready for today on caregivers of 193 individuals with Phelan-McDermid syndrome. And this was published in our journal Sleep, which is our major sleep journal for our sleep societies. And I was impressed that 90% show evidence of sleep disturbance, which is even higher than in autism, where it's estimated to be 50 to 80%. But only 22% of the caregivers said that their loved ones had undergone a formal sleep assessment, which is really striking and is something we also find in autism and other developmental conditions, where there's this disconnect between what the parents are reporting in terms of sleep and what is actually happening when they go to their doctors or nurse practitioners or whatever, pediatricians. And I think I have some ideas on why that is, and we could talk more in the Q&A. But I think oftentimes other problems are overshadowing the sleep problem, like limited language or behavioral challenges like aggression during the day or whatever. And people don't always make the connection between sleep and some other things that might be going on during the day. And that's one of my goals today, to try to help connect the dots in that way and talk about the importance of sleep on daytime functioning. And then it was also impressive that there was a greater total sleep disturbance in individuals, predicted the greater total sleep disturbance and daytime sleepiness in caregivers, which kind of makes sense. If you're waking up in the middle of the night to care for a child who's waking up, it's going to affect your sleep as well as a parent. So I thought that was really a very interesting set of conclusions. And then these are just a couple of figures from the paper. We use something called the Children's Sleep Habits Questionnaire in a lot of our sleep research across disabilities. And here you can just see that they found that things like bedtime resistance, sleep onset delay, sleep duration, sleep anxiety, night wakings, parasomnias, which are unusual behaviors in sleep, sleep disordered breathing and daytime sleepiness were about as common in the Phelan-McDermid sample as in clinical samples that had been studied previously by the creators of this questionnaire, Judy Owens and colleagues. The black is more the control, like just people who are kind of out there in the community. So you can see the black is less for a lot of these symptoms. This was on a scale based on what the subscale symptoms were averaging out to. But you can see what the point here, as I want to make, is that Phelan-McDermid is really affected. Many different symptoms are affected in this condition. And this is something I just wanted to take a moment of and put in the chat if you're able to, or the Q&A or whatever you have access to. I really want to get a better understanding from you all as to what kinds of sleep problems you are seeing in your children, your loved ones, if you're more in a capacity where you're helping support people and families with Phelan-McDermid, what kinds of sleep problems you're hearing about. So maybe take a moment and put in the chat kind of what you do, like, are you a caregiver? Are you someone who supports families? And then what you've heard, if anything, like, have you heard of any sleep problems, or as a parent, what kinds of sleep problems are you seeing? And then we can go on. Okay, so let's see. Alicia, is that going to work? If people put things in the chat, will I be able to see them?
It seems like the chat is disabled for some reason. I may have set it up that way. I apologize, everyone, but we are getting comments in the Q&A.
Oh, good.
So if you all would like to just continue entering them in the Q&A, I think all of us panelists can see them coming in.
Yeah, I'm seeing them right now. Thank you. Yeah, I'm glad you brought my attention to that. Thank you. Yeah, just use the Q&A because we can see them. And I'm actually, are they projecting right now on my screen? Well, I'll just read them out. Early morning waking at dawn. I saw that a lot. Yep. Early morning waking. Will not sleep during travel. We've seen early waking, nighttime wakings, even with medicine, difficulty falling asleep. We did do a sleep study which showed hundreds of times during the night when our son woke up and went back to sleep, it was markedly abnormal. Night waking, short sleep duration, general fatigue, night wakings, co-sleeping, trouble falling asleep, night wakings, difficulty falling asleep, calming. Wow, you guys are amazing. You're doing such a great job putting this in because, oh, my son wakes at times very distraught, screaming. Yeah, that's a real concern that we hear a lot. Early morning waking, middle of the night waking, difficulty falling asleep. My daughter has difficulties sleeping lighter nights. This effect has mental health problems, triggered a mania, and then psychosis. Wow. Thank you all for answering those. Because I think that really does give me a great flavor for, I'm just going to go on to the next slide, for what we observed. This is also from the same paper that I mentioned in the sleep journal. And you can see here exactly what you guys put in the chat. Child has difficulty sleeping away from home, does not fall asleep in their own bed, needs the parent in the room to fall asleep. And then there's a lot of reflections on trouble falling asleep, waking up during the night. So if you look here, the black is usually, and the gray is sometimes. So there's a lot. I mean, if you look here, there's a lot of concerns being raised about all of these issues. There's also child wakes up very early in the morning. A lot of you said that was a real major concern. And if you look here, that's actually like number one that has been reported by about 80%. So lots of resonance and congruence between what you guys put in the chat and what has been reported in the literature. And some of you may have actually participated in this survey, so maybe that's also why the results of this paper are matching up with what you're saying. But that was really, really interesting to get that. So thank you for all for putting in the chat and playing along. Now, I'm a clinician and I like to present cases. So I'm going to talk about this guy named Alex, little guy named Alex, who is very common. I mean, this is a real person that I've seen in my clinics, but I hear the story a lot. And I'm going to fall back on autism because that's what I know best. But I think that there are some similarities with Phelan-McDermid and other neurodevelopmental conditions. So Alex is 10. And as I go along, let's do another interactive thing. I want you to put in the Q&A what strikes you as a way that Alex could sleep better. Like, what can we do to fix his sleep? This is kind of like one of those pictures you see in a book that says, find the 10 things that are wrong in the picture, like, you know, the clock's going backwards, or some animal is hanging from the ceiling. So this Alex story, I want you to be thinking about all the things you can do to fix Alex's sleep. Okay, so let's go. So he's 10, and you can just put him in the chat. I'm sorry, in the Q&A. Bedtime is 8 p.m. He takes hours to fall asleep. He takes methylphenidate in the morning and also in the afternoon for his attention deficit hyperactivity symptoms. Methylphenidate is also known as Ritalin. It's a stimulant. He loves his Mountain Dew. He plays video games after dinner, and he can't settle down to go to sleep. So he leaves his room repeatedly to find his parents, and they rub his back to help him fall asleep. And then once he's asleep, just like we heard, he wakes up multiple times during the night. And he sometimes comes to his parents' bedroom. He falls asleep there. He might snore in his sleep, and he's very restless with leg kicks. And in the morning, it's really hard to wake him up for school. And his teacher describes him as being sleepy as well as aggressive in class. His parents, as you can imagine, are exhausted and very overwhelmed, not just from waking up in the middle of the night, but all the stress from the school and everything. So let me go back to the Q&A and see what's in there. Yep, you guys are doing a wonderful job. No Mountain Dew, no video games, no sleeping with parents. Yep, easier said than done sometimes, but you're on the right track there. I'm just gonna grab some water. I also see reduced sugar from beverages. Ooh, this is a good one. Change bedtime to later if he's not sleeping at that time. That is a really, really good one that a lot of people don't always pick up on. But what it is we all have a tendency to go to bed at a certain time. And what can happen is, if we are going to bed too early, we're actually in something called our forbidden zone for sleep, where we just are not ready to go to bed at that time. And many of you might have experienced this, like if you go to bed at, I don't know, 11 o'clock at night, but you have to go to bed earlier, like 9:30 or 10, because you've got a plane to catch the next morning. If you're anything like me, I get into bed early and I'm lying awake trying to fall asleep, and I can't because my brain is not ready to go to bed until 11 p.m. And it makes it worse sometimes if we, go to bed too early, because our brains are just not ready to go to bed. And sometimes our most awake, alert time of the night is right before we're ready to go to bed, like, half an hour before. So I agree with that recommendation to try to move bedtime later so you can kind of get out of that forbidden zone. Reducing screen time, that makes sense. Using a dark, cool room, weighted blanket. Yep, some kids do better with weighted blankets than others. We'll talk about that, and some other things we can try. Consistent routine. Wow, I am really, and we need to check on why he's snoring. Excellent. I'm really impressed because you guys are already kind of ahead of the curve in terms of knowing all of these things that I'm going to go over. But just to reinforce some of what you reviewed or what you pointed out to me and to others, I like to unpack Alex's sleep problems into 3 major categories. And I realize this is simplistic, but it really helps me as a science communicator, a health communicator, communicate really simply to people in ways that are easier to understand and more digestible. So there's the medical bucket, the biological bucket, and the behavioral bucket. So starting with the medical bucket, this is where, for example, the question that I just read out about the snoring. Why is Alex snoring? Could he have sleep apnea? Could the snoring be waking him up at night so that he can breathe, which is what we want to do. If we stop breathing, we want to wake ourselves up to breathe, because when we're awake, we can catch our breath. Sleepwalking, ADHD, all of these things can interrupt sleep. The stimulant, the methylphenidate, the Ritalin, particularly afternoon dose, can interfere with sleep. Leg movements, leg kicks can interfere with sleep. Seizures, GI problems, anxiety, depression, and then all these medicines. Some medicines like the methylphenidate I mentioned, but also medicines to treat anxiety, depression, medicines to treat seizures, they can interfere with sleep. So that's, to me, the medical category. And then the other huge category is what we call behavioral. It's not really the kids or the child's behavior. It's more things that we do that interrupt sleep or interfere with sleep as part of our lifestyles. You can think of it like that. So it could be the Mountain Dew, it could be iced tea, it could be video games, it could be that I mentioned that early bedtime and why sometimes you have to push bedtime later, particularly as kids get into puberty. Like Alex is 10, and we find that when you're prepubertal or going through puberty, our natural levels of melatonin shift by about 2 to 3 hours. So you need to go to bed later because the melatonin isn't released at the time it used to be released when you were a younger child. Parent interactions, such as rubbing the back. What we have when we fall asleep is what we need when we wake up to go back to sleep. So if Alex's back is being rubbed by his parents, that's well and good. He falls asleep, but then he wakes up in the middle of the night like we all do. And if his parent is no longer there to rub his back, we're going to transform a brief waking into a full-blown waking. So paying attention to that. Limited exercise, stimulating activities at bedtime. And then in autism, we have a lot of this sensory sensitivities, restricted interest, communication challenges. Some of this is also present in Phelan-McDermid. And these can interfere with sleep as well. So a lot of people say, well, kids with disabilities, they're not going to really be responsive to these behavioral strategies. They absolutely are. We found that in our research, that all of these things can make a difference in terms of improving sleep. And then there's this biological category that is being over-aroused, not being able to turn our brains off. Sometimes genetics can play a role. So the same genes that affect sleep can affect the neurodevelopmental condition. And then melatonin processing, which is something that I paid a lot of attention to and I continue to be fascinated by. I'll just mention a few things about natural melatonin, not the kind we get at the supermarket or the health food store, but our natural levels of melatonin are released in the dark. It's a hormone of darkness. Light suppresses melatonin. And as it gets darker at night, we release our melatonin. There's different actions that it has. Depending on receptors in the brain, it might either be hypnotic and promote sleep, also known as inhibiting the drive for wakefulness. It can also be chronobiotic, which is a fancy term for being a synchronizer of our circadian rhythms or our biological clocks. And these are different kinds of receptors in the brain. We call them MT1 and MT2 for hypnotic and chronobiotic. And then what you might not know is, this was news to me when I first read about it, that melatonin may also act as an anxiolytic, so to decrease anxiety and to mitigate hyperarousal, or that kind of I can't turn my brain off feeling. And this is really fascinating because this may be as important as it being a hypnotic or a chronobiotic, is being able to relieve anxiety and fight against or mitigate hyperarousal. And that may be why it works so well in certain populations, like kids who are over aroused. I want to also point out really briefly, but it's a key thing, that emotional regulation is affected by sleep, even in people without neurodevelopmental conditions. Something called functional MRI, where you can measure blood flow in the brain, and this shows you what parts of the brain are active. So if you were to look at really scary images of bugs crawling or whatever, and you were in an fMRI scanner, a functional MRI scanner, the part of your brain that would light up would be your amygdala. And the amygdala is a fear-based center deep in the brain. And then the front of the brain, we call it the prefrontal cortex. This is the part that keeps our emotions in check. Would not be functioning as well. There'd be decreased connectivity or decreased connections between the front of the brain, the prefrontal cortex, and the amygdala after you were up for 24 hours or more. So those studies have shown that. Now, kids who are who have developmental disabilities are even more susceptible to that increased amygdala activation and that decreased connectivity. So it's kind of like when they're sleep deprived, they even have less emotional regulation. And you need that connectivity to kind of keep your emotions in check. So that's one line of evidence connecting sleep and emotional regulation. So we not only feel bad and grumpy and grouchy when we haven't slept, there's actually a biological reason for it that's been shown with these studies. And then my colleague Olivia Veach published with me in on this big genetics collections called the Simon Simplex collection, and looking at more than 2,700 children with autism, found that the less they slept, the more severity scores they had for core symptoms. So restricted repetitive behavior and social interaction, social communication were affected. And then the other study by Sol and Mazurek looked at sleep problems, and they were significantly associated with aggression, irritability, inattention, and hyperactivity. Now, this doesn't necessarily mean, this isn't causal, this is more an association, right? But the idea is if you can improve the sleep problems, you can maybe show, and the aggression and all these other things get better, then maybe you can show that improving sleep makes a difference. And that's the kind of work that I've embarked on in my career. I'm very interested in how do we help parents get their kids to sleep. And we basically find that we can do it. The challenge is how to do it. Like, how do you deliver these behavioral strategies to children through their parents? How do we get parents who are overwhelmed, like who are just trying to get through the day and are up all night? How do we actually teach these to them, get them to use them? And how do we know who actually needs medicine? So I'm going to go through this fairly quickly because you all did such a great job identifying things in the chat and in the Q&A. But I like to think of sleep habits as a holistic way. I like to think about not just what happens at night, but what happens during the day, what happens in the evening, and what the sleep environment is like and what the bedtime routine is like. So we put together this family inventory of sleep habits back in 2009, because there really was no questionnaire that we could really give parents that was quick and simple, and would get at questions like, my child gets exercise during the day? Is it never, occasionally, sometimes, usually, or always? You can see all the questions here. Caffeinated beverages, engaging in a bedtime routine, engaging in relaxing activities. So this basically, I could take this and I could have a parent fill it out really quick in the waiting room, and then I could give them some really quick and simple things to focus on. And, things like, is there enough exercise during the day? Is there abundant light? Are they limiting caffeine, limiting naps? Because naps are good, but if they're too late in the day, they can interfere with sleep at night. They can interfere with that drive to sleep that we all need and we all have. And then bedtime use, like making sure we don't use the bedroom for time out, because then the child will have a negative association with that. At night, limiting stimulating activities, less light, more routines, those kinds of things, making sure the sleep environment is comfortable and quiet. And it really needs to be individualized for the child. So my younger son, I thought, let's close the door, let's turn out all the lights, so pitch black, quiet. And it just didn't work for him. He couldn't sleep because he was really anxious. So we opened the door so that he could hear sounds from the rest of the house. We put a little nightlight in, and he did great. So, really trying to be individualized to the child. And we do that also with our bedtime routine. This, again, I pull from autism, where kids are very visual and they love to move these little icons around. Some prefer, if they have more language or they're older, prefer a little checklist. But you can individualize these to the child. You can have, like, for example, reading a book toward the end, but it could also be listening to music or telling a story or playing with Legos or whatever. And this is really, we found very helpful. Now, at this point, you're probably saying, well, what if my child doesn't talk? And what about limited language, which I know is a big issue in Phelan-McDermid. So there are strategies for everyone. So one of the strategies that I really love that we developed as an alternative to kind of the Ferber crying it out technique, which doesn't really work very well. I don't think, I mean, it works for for kids who are typically developing, but for kids with disabilities, they don't understand what they're being asked to do, to fall asleep without their parents there. There's a lot of anxiety. The parents are going to feel anxiety about trying to do that with their child with a disability. So we do something kinder and gentler. We call it the rocking chair method, and it's letting your child fall asleep in their own room. But you on his or her own, but you're in the room sitting in a comfortable chair. It doesn't have to be a rocking chair, any comfortable chair with your back to the child. So your child knows you're there, but you're not reinforcing a lot of like giving attention and all. You're just kind of saying, go to bed, very brief and boring, but you're there. You're there to comfort your child. And then the idea is you move the chair closer to the door every night until you're out of the door. And you can reward with morning stickers, baskets of presents, something that rewards, so that you're using a carrot, not a stick. And you can also do this for co-sleeping. Like, let's say you're in the same room or the same bed with your child. You could bring a new mattress in, so you're on a separate mattress, but you're right next to the child. Your mattresses are touching, and then you move the mattress further and further away until it's out of the room. And then night wakings. I mentioned this earlier with the rubbing Alex's back. We all wake up at night. If we don't have what we had when we fell asleep, like the classic example is the infant with the pacifier. The pacifier falls out. The infant normally would wake up, go right back to sleep, but because the pacifier fell out and they needed that pacifier to fall asleep, they wake up and it turns into a full-blown night waking. So I explain this a lot to people in clinic, the parents that I help. And it really makes a lot of sense, because this is how you not only treat night wakings, but you try to get the child to fall asleep on their own at night. And then that helps this. And we also talk about responding quickly to distress, remembering brief and boring, but be careful not to over respond. Like if there's a monitor that's picking up all the sounds from the child, just try to limit that. Over response, and sometimes you can incorporate like these visual reminders and rewards, and choosing realistic goals, like we're not going to necessarily have the child in their own room right away, but let's see if we can at least get them in their own bed within the parents' room. Limited verbal skills. I love these because they work for any child, even if there's limited language. Rocking and swinging, a variety of things that can be used. And I'll show you in a moment where you can get these brochures and pamphlets and all, but different things work for different kids. As I said, some like weighted blankets, some like calming scents, some like music. You might put a continuous music player on for your child. First, we're going to go to sleep, and then we're going to watch Disney, putting stop signs on the door so they have a humorous but an important reminder, firm reminder to stay in bed. And then all of these are available. So I developed these for Autism Speaks. We're now the Autism Care Network. It used to be called Autism Treatment Network. But these work regardless of disability. They work in a variety of, I've given them to kids with Down syndrome, and they work in a variety of disabilities. And if you could simply search on the internet for Autism Speaks sleep toolkits, they'll all pop up. And you can even get like visuals so that you can put together bedtime routines. There's something on melatonin. This is not part of it. This is a book that I published with Terry Katz that you can find on Amazon. And we wrote this book because we knew that not everybody had access to these coaches and behavioral therapists. So that's why we wrote the book. And it's kind of like a step-by-step thing. And again, it doesn't have to be autism. I think it could work in Phelan-McDermid as well. So I just wanted to make you aware of that. We've also practiced or piloted working with therapists in the community. I'm really excited about this work that we published last year because what we found was that going to see a sleep specialist could take months at an academic center, even if you might not even have access, but everybody has access to therapists, behavioral therapists, speech therapists. So could we ask the pediatrician to simply make a referral to the specialist and also make sure the pediatrician makes sure there's no apnea going on, no reflux or some other issue. And then we let the therapist take it from there and train the parents in the techniques that I just kind of went over with you. And the therapists did great. We call it fidelity when they're able to be consistent with the training program. The parents understood what was being asked of them with what to do, and the sleep patterns and sleep habits improved in the sample of 30 kids with autism, and they were very happy. The parents were very happy. The educators were really happy. We also went online during COVID, and we gave parents a toolkit that consisted of either very brief videos combined with some of the pamphlets I just showed you, or we just gave them the pamphlet alone. And we did it all online. It was really amazing because most of our studies during COVID, we really had challenges recruiting for because people didn't want to come to the clinic and get exposed, or or they were sick. It was really, really hard. But what was lovely about the study was it was all online. So we did the consenting online. They filled out surveys, including that children's sleep habits questionnaire I mentioned earlier online. They got their interventions online, and they would unlock things. So they would unlock their surveys after they enrolled, and then they would get access to the materials after they completed their surveys. And we did it in Spanish as well as English for families that were bilingual. And they really liked it. And I think this is another way to get material to families is to do things online. We were able to exceed our goals and randomize more than 140 children. We actually randomized the parents of the children to these studies measures. We didn't see great improvement, but we did see improvement in that family inventory of sleep habits score was related to improvement in their total children's sleep habits questionnaire. So that was good. And the key thing for me was we were able to deliver an intervention online as well as consent and complete surveys online. So I think it really speaks to online surveys. I'm just going to spend a few moments on medicines, and then we'll do questions. I really have found that melatonin is the most studied medication, not just in autism, but other neurodevelopmental conditions listed here. The key thing with melatonin is there's minimal adverse effects, because we're giving something that our bodies normally make. We're giving it at higher doses, but really minimal effects. Like a rare child might have more drowsiness in the morning or increased bedwetting, but nothing super serious. And I basically have found in my researching the literature, we did a study at Vanderbilt with more than 107 kids and found minimal side effects and improvement. But when you look at what we found and what the literature has shown, a few key things are immediate release melatonin, which is what's usually available, works best for falling asleep, sleep onset delay. Melatonin only stays in our system for a short period of time. So for the night wakings and the early morning awakening that you're seeing in Phelan-McDermid, we're probably going to do better with a longer acting melatonin preparation. And unfortunately, you have to be able to swallow pills to take that prolonged release melatonin. But I did mention there are studies going on with a mini tablet that's easier to swallow through that Neuron Pharmaceuticals. And I was able to participate in some trials and help consult. And they did see efficacy in the 13-week trial with a maintained efficacy of 2 years. So now we're just waiting for the FDA to approve it. And hopefully that will happen in the next year or so. Other than melatonin, and this is just showing, this is like your immediate release. I'm sorry, down here, your immediate release, and then your sustained release. And you can see why sustained release or controlled release works more on night wakings, because it's working all night long. Otherwise, it's really a grab bag of medicines. And I just wanted to say it's trial and error. We studied gabapentin at Vanderbilt. We had some good responses. Also, people studied clonidine, which is an alpha adrenergic agonist, with some good responses. Trazodone, hydroxyzine. Some of these other ones have not really been studied. They're being used, but they haven't really been studied very much. Mirtazapine was studied in one trial. I don't want you to get caught up on the names, because again, I want this to be something that you would talk to your child's doctor about anyway. But I just wanted to make you aware that there are no approved drugs for sleep at this time in kids. Even the melatonin, we want to make sure pediatricians are aware about, so that we don't end up with drug interactions or missing underlying conditions like sleep apnea or other conditions. And then I'm also super wary of some of these over-the-counters like the CBD, because I just don't think we know enough about what they do on the developing brain. So I'm going to skip over these slides and go to my summary slide so that we'll have time for questions. I hope I've showed you that sleep difficulties, I focused on autism spectrum disorder because that's what I know best, but I think that these work and are generalizable, the principles I've given you today, to neurodevelopmental disorders in general and Phelan-McDermid as well. Once we identify the cause, sleep difficulties are highly treatable. Behavioral treatments do work, behavioral approaches. Medicines all have side effects, but are sometimes appropriate. And what I'd really love to see as a future direction is input from families. Just like you gave us input today in the Q&A, we need to know like what matters. Like if a child is taking 20 minutes to fall asleep, it may not matter as much as if they're waking up multiple times a night, right? So really understanding what the concerns are. And then when we do use medicines and behavioral strategies, how well they're working for you all. And I think that's vital to moving forward and improving sleep in this population. So I will go ahead and stop my slides and take questions. Thank you for listening.
Well, we got some great questions. Thank you so much for that great presentation. Two, surprise, surprise, you would the best person to answer these One person asked if there have been any studies so far looking at the levels of melatonin, and I assume in the blood, in individuals with PMS.
That is a great question. I do not know the answer to that. If anybody else does, I'd love to hear. I did a little bit of a research dig and I didn't see it in the literature. But what I will say that's really interesting is we studied that in autism and we expected to find lower levels because all these other people in the literature had found them. And we were doing a study giving kids supplemental melatonin. So we did their levels before we gave them the melatonin. We actually brought them into our clinical research study and put IVs in, and we were able to get repeated blood samples. So it was a tiny sample of 9 kids, and they were all kind of level 1 autism, like very verbal and all, because, you know, to go through that study, you have to be at a pretty high level. But we found normal levels of melatonin, which shocked us because all these kids went on to get supplemental melatonin and their insomnia was better. So how did we explain that? And the way we explained it was, you know, when you've seen one kid with a disability, you've seen one kid with a disability, there's a lot of variability. And maybe we weren't treating lower levels, we were treating hyperarousal and anxiety. So, you know, or stabilizing their biological rhythms. So I would just say that even if you don't measure the levels, and even if you haven't proven that they're having low levels of melatonin, melatonin can still work in kids with normal levels because you're giving kind of like extra, or you're giving a level that might be helping with the anxiety and the hyperarousal. So that's my lesson. With that said, I would love to see some studies of melatonin. And the other cool thing is you can do it with saliva. You don't have to do it with blood. So you can take salivary samples in the evening. And we, you know, we've done this and others have done this in adolescents as well on the spectrum. So great question.
We have another one kind of similar. It's, and I don't think this is within people with PMS, it's just in general. When you give melatonin, like a gummy or a tablet, how does that impact the endogenous melatonin that's produced? Does it? Have those studies been done?
Yes, that is always a very frequently asked question because of the concern of, if I give something, is it going to affect my own levels? And the answer is, from the research that we've seen, we haven't researched it in PMS, but we've researched it in other conditions, is no, it is safe. In other words, they've shown that they can actually differentiate with some of these labels between, like you can label your own melatonin versus the melatonin you take, and the melatonin on your own that's labeled doesn't change. So in other words, you're continuing to produce your own melatonin. You can think of it as a supplement. Like we all make these nutrients in our bodies, but we still might take a multivitamin. So the multivitamin isn't keeping our bodies from making those nutrients or having those nutrients accessible. It's just kind of boosting them or amplifying them if we need a little bit of extra help.
So we have another one I think that everyone can relate to. Their 18-year-old goes to sleep in their own room, but then wakes up in the middle of the night at, of course, the witching hour of 2 or 3. If they're put back into their room, they won't go to sleep. If they come back into the parents' room to sleep and cuddle in bed, they go right to sleep. Clearly, this isn't a long-term sleep strategy. So do you have any ideas to help with this situation?
Right. So this gets at the, well, there's 2 things. One is it gets at the set realistic goals. So the first time I see somebody in clinic, I'm not going to say to the parent, you can't co-sleep. You just can't do that. Because, I mean, this is working at some level for them to get sleep at night. Now, do we want to try to ultimately get the child in their own bed? Absolutely. I will commend the parents for starting out at the beginning of the night with the child in their own bed, and then unfortunately they come to them. And I would really work on what's going on at bedtime. I would go back to that principle of what we need when we go to bed is what we need when we wake up. And is there something that's happening at bedtime where the child is falling asleep with the parent doing something, being physically there, rubbing their back, whatever. And can we actually get the parent where they're soothing their child at bedtime, but then leaving the room, or at least leaving the bed and getting into a chair maybe? Can we do that so that the child finishes the process of falling asleep on their own without the parent having to do that? And if you can get to that point, maybe with a little bit of melatonin or gabapentin or clonidine or whatever, even temporarily, if you can get the child to that point where they can finish the process of falling asleep on their own without their parent right there, then I think you can cut down on the night wakings. But it's a process, and you've got to put rewards into place. You've got to work with the parent. You've got to say, hey, does this seem reasonable to you? If you just tell the parent what to do and you don't actually get their input and say what's going to work for you and your child and your family, they're just going to leave. I mean, I've had this happen, and they just leave and they're like, well, Dr. Mallow is really smart, but we're not going to listen to her because we can't do it. So really understanding where the family is coming from is, to me, the key in all of this. Great questions.
I know, aren't they good questions? We have another good one. There's a lot of sleep apps out there, Fitbits, Apple Watches, all sorts of different apps to track sleep. Do you have a preference? Do you have one that you like? I know you're not a spokesperson for any of them, but what do you suggest?
Yeah, so the first thing I'll say about the apps is use whatever app you have. Don't go out and buy another app. Like if you've got an Apple Watch or Fitbit or whatever, just go ahead and use that. But regardless of what you use, and I think it's fine to use it because you learn about sleep, and I'm happy to, when parents bring in the little, the downloads and we review them together because we're all learning about sleep together. Keep in mind that they're not perfect. They're consumer products, so they're not going to be as good as like the research reliable things that we can give you. We call it actigraphy, if you ever hear that term. But they are okay. I mean, what I've found when I've worn one is that they actually underestimate sleep. Like they tell me I'm up a lot, but I know that I've stayed in bed, and it'll tell me that I'm waking up and moving around, and maybe I am. The problem is that it's using movement as a surrogate for wake. So if you move around a lot in the bed, or your child moves around, it's going to record that as awake because it's not measuring your brain waves, it's measuring your movement. So you just have to be careful with the numbers and not freak out. Like don't freak out and say my child is only getting 6 hours of sleep, because they may actually be getting many more hours. They're just moving around in their sleep. And I use it in a way, like if a parent is concerned about something they see, we could supplement it with sleep surveys and logs and diaries, and also sometimes even do a sleep study in our lab with the device on, so that we can actually compare what the device is doing to what is actually happening. But I do think from an education standpoint, they're very helpful. They're also good to track over time. Like if we start melatonin or we start a behavioral routine, it's really helpful to collect data before, during, and after, and then you can learn what your treatment might be doing.
We have a question that kind of popped up during your presentation when you were asking about sleep difficulties, which is sleep when traveling. So do you suggest something over the counter, not for daily use? So something that would be, just every once in a while. So is there, I know you mentioned that you may not want to take every day. But is there something around traveling specifically?
Yeah, so clearly melatonin is great. If your child is only having problems when traveling, or if you use melatonin at night and they need just a little bit more to boost them, you could use a little more. I tend to stick with 1 to 3 milligrams for melatonin, but I've occasionally gone up to 4 or 5 or 6. So that might be a time if you're traveling just to boost it. a little bit when you're traveling. I also think something like Benadryl could be good. It's over the counter. You have to be careful. I would definitely, before you travel, I would try whatever you want to try when you travel so that you don't have a paradoxical reaction where your child is more awake than they normally would be. That's called rebound or paradoxical reaction. So those are the two that come to mind. As be very careful, read the labels, because a lot of times like these sleep aids, they have a lot of stuff in them that you don't really need, including like Tylenol and all. And I think sticking with like the melatonin or the pure Benadryl is helpful. And then talking to your pediatrician about just there are some other very simple sleep aids that could be tried just for traveling. And I think it's reasonable to use that. If it's just a short term type of a thing, it's really not going to get your child in danger.
Her 19-year-old is awake and banging on the walls. The room is dark and there's no parent. He's been asleep for about 3 hours.
Yeah, it's hard. I'm gonna be careful here because I really would need to know a lot more about your son, Andrea. Like, I'll just say my basic principle is I always start with the medical, right? Just like I showed you those buckets, and really making sure, and this is where his doctor can help, his primary care doctor, or if he's still seeing a pediatrician, like really making sure that there's no underlying medical issue, GI issues, sleep apnea issue, seizure issue, even things like eczema and all. So that's where I always start. And, then I would probably move on to, what is the bed? Like, is he going to bed at the proper time? Does he need to be going to bed later? Looking at kind of all of those different layers that I went over. It's really hard. I wish I could give you more advice without knowing more about him, but kind of looking at those different layers can be very helpful. The medical, the biological, and the behavioral. And then the other question from Laura, my child also developed periodic limb movement disorder. Yeah, I don't know if it's related to dystonia, but it is very common, these leg movements, particularly if you're having like restricted diets or whatever, and you're not getting enough iron, red meat, because iron is involved in keeping our legs stable at night and preventing restless legs. And we call them periodic leg movements of sleep. Can be leg kicks that can come from low iron, and it can run in families. So getting that checked out is really important too. Making sure that we call it the ferritin level, which is iron stores, is above 50. And then I also think that one of the reasons gabapentin works so well is it treats restless legs and leg movements. So that is something to think about as a medication to ask your doctor about. It's prescription only. And then let's see, the last question I think is, can our kids be seen in our clinic? Absolutely. Yeah.
There was a question, sorry, about, there was one about, and I skipped, and I apologize, about the
sure.
long-term use of melatonin. Can you build up tolerance or resistance?
Yes.
And would extended use help, this extended release help?
Yeah, so I hear this a lot, and I don't know if the melatonin wearing off is a combination of it just being over time, your enzymes change and you metabolize it faster in some people than others, or if it's just people sometimes let the behavioral techniques that they're working on go. So what I tell parents is, do behavioral techniques like the bedtime routine and all, and what happens during the day, implement them with the melatonin, with the idea that then you can get off the melatonin. So the melatonin is helping you kind of get the behavioral techniques quick start and kicked in, and then you can let it go. Because I have seen that over time, that sometimes it tends to wear off and not be as effective. So really using it to kind of jumpstart the behavioral techniques, I think is good. It doesn't wear off in everyone, but I do see it wear off in some. And I'm going to put in the chat or in the, let's see, I'm going to put the number for Vanderbilt. We are very happy to see any of your kids that you need. That's our Vanderbilt Sleep Clinic. And sometimes we need to get a referral depending on your insurance, but myself and my colleagues are very happy to help.
Did you see the one, Dr. Mallow, about the girl who struggles with sleep specifically around or prior to her menstrual cycle?
Yeah, she has PMS. Yeah, I'm looking at that now. That is very interesting. I know that people have treated, we call it catamenial epilepsy or seizures related to your menstrual cycle. People have treated that, for example, with progesterone and progesterone lozenges, like natural progesterone. And there may be some impact where sleep can be helped as well, because we know, for example, estrogen is very stimulating. So, and progesterone is calming. So again, that would need to be done under a doctor's approval and doctor's guidance, and maybe even a referral to OBGYN for assistance. But that's something I would definitely explore, as like brief hormonal treatment around the time of the menstrual cycle, or maybe using a medicine just at that time, like melatonin or gabapentin. I think those were all the questions. They keep coming in. I'm so glad.
Yeah, there's one more, and this is a good one for everybody. So this is a family that has blackout curtains, but someone still wakens at dawn, I assume, even if no light gets in.
I mean, that's fascinating to me. That speaks to maybe a circadian rhythm or a biological rhythm where we're just done sleeping for the night, and now our bodies are ready to wake up, even if it's not light outside. And again, there's different things that can be tried there, including like maybe making bedtime. Like if a child is going to bed at 8 and waking up at 3 a.m., just seeing if you can move things like 10 p.m. to 5 a.m. might be easier on the child and the family. And that's something that could be done behaviorally. By keeping the child up a little bit later, maybe going for a walk and getting some exercise to stimulate them, and then they can have like a later bedtime and a later wake time. But again, these things can be analyzed and treated and with a little bit more detail to the overall child.
Well, I think that's it. Thank you for answering all of those questions, and thank you for being a part of this We Are Family series for this summer and fall this year. The organization couldn't have an in-person meeting, and so this has been a great opportunity for us to hear all sorts of different topics and get advice when we can't be together in person. So thank you so much. I'll let Kate wrap it up.
You guys rock. You are an amazing group of families, and I just absolutely loved this hour. So thank you for sharing your knowledge with me too.
Thank you all. Thank you both, Dr. Mallow and Halliday. This was one of the most engaging sessions we've had so far. We will circulate the contact information for Vanderbilt as well. I see we have a question about that. And thank you so much. This was a great session.